Thank you. Thank you very much, and welcome everyone back to the session this afternoon. Hope you've all had a good lunch. It's a great pleasure to be here. I'm from Sydney, Australia. It's my first time in Korea, and it's fantastic to be here for this great meeting. And thank you very much to the Global Fertility Academy and Merck Serono for making it possible for me to be here and all of you to be here too. It's a great thing for them to be doing. They've put together the slides with me, and I'm very happy to present them today. Hope we're learning things through the day, and there'll be a similar format for this talk, which is about vitrification and cryopreservation. We're really talking from a clinical perspective rather than protocols as such. And there are 6 really interesting talks, so I hope you'll like them. Okay, thank you everyone. So we'll see how we all do towards the end of the talk. So we have 6 really interesting presentations this afternoon to do with vitrification and cryopreservation. We start off with a talk from Sydney, in fact, looking at overall outcomes, looking at vitrification compared to freezing and fresh transfers. We then look at a study that looks at freezing embryos in an emergency situation where they didn't want to put the embryos back, and is putting a frozen embryo back a good strategy. We'll be looking at the freeze-all strategy in poor prognosis patients, and can they do well when they don't get many embryos? Is freezing okay in that situation? We look at an excellent study trying to show that freezing embryos is okay even when you put single embryos back. So as you know, there's been a general shift, as we'll see this afternoon, towards single embryo transfers in IVF. Freezing embryos has always been perhaps slightly more on the putting more than less embryos back, but this study looks at, is it okay to put single frozen embryos back? We'll be looking at the comparison between using frozen embryos that have been tested genetically by PGS and how they are graded morphologically, and how that works in that 5th study. And the 6th study looks at ovarian freezing and retransplantation, something similar to what we heard in the last talk. So the first study by Lee, this is from the University of New South Wales in Sydney, and this is looking at the whole Australian database. And the idea of the study was to compare clinical outcomes in blastocysts, in embryos which had been either put in freshly or frozen by either vitrification or slow freezing. Background to this is that vitrification, we know, has been associated with increased post-thaw survival rates compared to slow freezing. I think everyone thinks vitrification is definitely a good thing, but there's been lack of general consensus so far over which type of freezing method is good for blastocysts in particular. And there's been just basically less evidence on blastocysts. So the aim of the study was to determine the clinical efficacy and outcomes following vitrification of blastocysts compared to fresh blastocyst transfer and slow freezing methods. So this was a large population cohort between 2009 and 11 in the whole of Australia and New Zealand, 46,000 fresh blastocyst transfer cycles, 11,000 frozen blastocyst transfers, slow frozen, and 19,000 vitrified blastocyst transfers. Huge numbers. So first of all, you can see there that the pregnancy rates are shown, the dark blue on the left for fresh blastocyst transfers, the green embryos that had been slow frozen and thawed out and transferred, and the light blue, the vitrification. So as you can see, that compared to the slow freezing, the vitrification, the light blue on the right, resulted in higher clinical pregnancy rates and higher live birth rates. There was also, compared to the slow freezing blastocyst, vitrification had comparable perinatal outcomes. So the green and the light blue were similar in terms of fetal death rates and perinatal death rates. And both of them were better compared to fresh transfers. In fact, there was improvements in preterm delivery rates and low birth rates. In fact, compared to fresh transfers, preterm delivery rates were reduced by 14% in vitrification cases. Low birth weight rates were reduced by 33% in vitrified cases compared to fresh transfer cases, and small for gestational age was decreased by 40% in vitrified cases compared to fresh cases. So compared to fresh transfers, vitrification of blastocysts actually had better perinatal outcomes. Very interesting conclusion from the study then. So compared to slow freezing, vitrification was better in terms of higher clinical pregnancy rates and delivery rates, comparable neonatal outcomes compared to slow freezing. And the clinical implications are actually quite far-reaching if we think of that last slide, because the suggestion here is that vitrification should be considered as an alternative embryo transfer strategy to improve overall clinical outcomes as an elective thing. So very interesting final conclusion. Vitrification definitely appears better than slow freezing and may even be better than fresh transfer. The next study. This is from Milan and looked at freezing embryos in a rescue situation for cycles where they didn't want to put back a fresh embryo. So in good responder patients, extended culture to the blastocyst stage is associated with higher rates of implantation, clinical pregnancy delivery rates compared to transfer of embryos on day 3. I think many of us would agree with that blastocyst transfer has been an overall improvement. And vitrification, as we've seen, is now being applied even to blastocysts, and that appears to be a good thing. So what about postponing the embryo transfer in a simulated cycle where the implantation window, the time of transfer, may not be best for the patient? So the aim of the study was to see whether elective freezing is better for some patients. This was a retrospective study. There were 252 cycles performed in 2012 and 2013. So the outcome of 63 postponed cycles in cases where fresh transfer is contraindicated, and this was essentially almost entirely because of overstimulation, and they wanted to not put the embryo back to avoid ovarian hyperstimulation syndrome, were compared with fresh embryo transfers, 189 of those. The patients were matched by age and ovarian reserve and cause of infertility and the number of eggs collected. The pregnancy rate was defined as the positive HCG. So first of all, you can see that the frozen embryo group were in fact slightly younger, and they had slightly more eggs collected. Up there, sorry if you can see, very hard to use a pointer from here. And the frozen group did have fewer blastocysts transferred compared to the fresh group, slightly fewer blastocysts transferred. But the pregnancy rates were strikingly different, and these results I found quite impressive. Frozen embryo group had a pregnancy rate of 71% compared to the fresh group of 55%. Implantation rate also significantly different. So those really were in favor of the strategy of freezing embryos in this situation. The clinical pregnancy rate and the ongoing pregnancy rates were also better in the frozen groups, although, as you can see, didn't reach statistical significance, but the study wasn't powered for that, but clearly it's looking at the same trend. So implantation pregnancy rates may be superior when an FET, a frozen embryo transfer, is performed in clinical situations where the fresh embryo transfer is contraindicated. So I say again, this is something like a situation of ovarian hyperstimulation, and you're freezing for that reason. And it's okay then to freeze embryos in that situation and put them back in a later natural cycle perhaps, and the theory is that there may be better synchrony between the embryo and the endometrium. This is not a randomized trial, and certainly more research and prospective trials would be good in this field. But the principle is certainly good, so implantation and pregnancy rates in these types of ART cycles may be improved by freezing and elective transfer. Okay, our next study is from Rome and is looking at the idea of freezing embryos in patients who might have a poor prognosis. So we're not expecting many embryos. And the idea behind the study is that, well, often if we have few embryos, we tend to just put them back rapidly. We're scared of losing them, or that we're scared of the patients not having an embryo suitable for transfer. And certainly, previously with slow freezing, we were worried about how many embryos would survive the freezing. And so that has been the underlying clinical approach so far. But with vitrification now, is it possible to freeze and get good outcomes even when we have relatively few embryos? So the idea of freezing blastocysts we've already seen in the last 2 or 3 talks today has shown that freezing blastocysts is a good thing. The outcomes seem to be good, potentially even better. But is this going to be okay for poor prognosis patients? And in this particular study, they defined poor prognosis patients as you'll see, older women and people having PGS in particular. So that is a big point about the study. They're not generally poor prognosis patients. They're patients who've been selected to have PGS, pre-implantation genetic screening for aneuploidy. So all these cycles involved PGS, the aneuploidy screening. They were freeze-all. They were all blastocyst biopsy. And this was, again, between 2012 and 2013. The indication for PGS in this group of patients was advanced maternal age, which is where the woman is over age 37. And the outcome was, again, implantation rate. They only did single blastocyst transfers. And so the embryos were all biopsied, vitrified at the blastocyst stage, and then put back in a natural cycle. So there were 174 patients, and this went over about 193 cycles. The age ranged between 37 and 45. The average age was 40, as you see there. Although they describe these as poor prognosis patients, I have to say they aren't that poor from where I come from. So they had, on average, 8 eggs collected, and they had quite good embryo rates. So they were only poor prognosis in the sense that they were over age 37, but this particular group of patients seemed to do quite well, I would say. You can see that the blastocyst rate and how many survived were really, really good. Blastocyst survival, nearly 99%. So the ongoing pregnancy rate, the final number at the bottom there, was 50%, and that's of the embryos that went through this process. And just like all PGD studies, it's important to understand what these success rates really mean. So they've said on the bottom here that the implantation rate of patients entering the study was actually 23%. So many of these patients don't get embryos suitable for biopsy, or the results of the biopsy are abnormal, so they don't get a transfer. So whenever you assess the success rates for these kinds of studies with PGD, you must look at what the denominator is. What are we actually measuring? And so more realistic from the patient perspective, if I start a cycle like this, what is my success rate? So 174 patients go into this, and 41 ended up having a pregnancy, so 23%. But the point is, from this study, is that that's quite good, given that they only froze relatively few embryos, and those are the embryos they used to put back. So we get high blastocyst survival and the implantation rate after vitrification in, as we say, an older population, over age 37, average age 40. And so the chance of pregnancy was maintained in this group. So they were comfortable doing this even when they had maybe one embryo to use. So as they say here, this is a proof of principle study. It paves the way to the strategy for not being afraid to embark on this approach with patients who you may think may not have many embryos. This idea of biopsying them, doing PGD, freezing them, vitrification, and electively putting them back. More studies are needed again. Okay, this study is from Belgium, and this is looking at a change of policy there of putting back electively single frozen embryos rather than double frozen embryos. So in Belgium, since 2003, there was the system imposed single embryo transfer strategy for fresh cycles, and Belgium has been one of the countries leading the world in that. And this has certainly led to reduced multiple pregnancy rates without affecting pregnancy rates. And we'll hear more about this in my final talk at the end of the afternoon, in fact. But in frozen embryos, in Belgium, you can still put 2 embryos back. And so there has been cases where there have been both 1 and 2 embryos put back. And the idea of this study was to compare pregnancy and multiple pregnancy rates when single frozen embryo transfer was done and double frozen embryos was done over a period of 5 years. And the point about this study is that freezing strategies have changed over this time to include both slow freezing and vitrification. So it's been a fantastic chance for them to assess the difference between those freezing methods. So there were over 2,000 frozen embryo cycles, and all patients were included, whatever their age and indication. 1,600 cycles slow freezing were basically day 2-3 embryos. I think that's important to note. And over 500 cycles were vitrified blastocysts. And they looked at pregnancy and multiple pregnancy rates. So, really interesting table, this, I think. If you look at the slow frozen embryo column, you can see that when embryos are slow frozen, there is quite a big difference in pregnancy rates between double frozen embryo transfer, the DFET, 39%, and the single frozen embryo transfer, which is 27%. So in other words, historically, there's always been an advantage in putting back 2 embryos that have been slow frozen. And remember, these were actually day 2-3 embryos. So because of that statistical difference, it was often the case that we'd put back 2 frozen embryos in that situation. However, in the vitrified blastocyst case, you can see that the significance between those pregnancy rates disappears. So the single frozen embryo rate is much higher in the vitrified blastocyst group compared to the slow frozen cleavage stage group. So that means that there isn't much, there's a little difference, but it's not statistically different between putting back a single and a double embryo blastocyst in terms of pregnancy rate. So vitrification has changed the ballpark here. So it's okay to put back single embryos, although these are single blastocysts, remember. And this is translated to a huge side effect, which is an improvement in multiple pregnancy rate. So in the single embryo transfer group, you can see that the vitrified blastocysts, very low twin pregnancy rate, 1.5%, whereas if you put back 2 frozen vitrified blastocysts, the twin rate is 20%. So huge difference. Once we move to the vitrification stage, the outcome is so much better that we are at high risk of multiple pregnancy if we're putting 2 embryos back. So the pregnancy rate doesn't significantly differ between between single frozen embryo and double frozen embryo in the vitrification embryos. Multiple pregnancy rates over 20% when 2 embryos are put back of vitrified blastocysts, less than 2% if you put back a single one. This is retrospective, and it's certainly not a randomized group, and as I said, the embryos that were put back were actually different stage embryos. But interesting nevertheless. We should watch out for multiple pregnancy rates, and if we move to vitrification, we really should be using that as another reason to move to single embryo transfers. And these findings have led this particular group to introduce a single frozen embryo transfer policy for everyone. Finally, for vitrification, this study, which is from California, and is looking at whether how vitrification can be applied to a program of PGS, pre-implantation genetic screening, and looking at how morphology relates to that. Interesting. So they've got this program going, Array CGH, which we'll hear more about in the next talk, aneuploidy screening with blastocysts, vitrification, putting the embryos back from a frozen vitrified embryo back into a natural cycle. And the idea was that we're not sure in that situation how much morphology testing adds to embryo selection. So looking at morphology of the trophectoderm or the inner cell mass, does that influence the outcome? So the aim is to determine whether blastocyst development and the morphology grading is correlated to implantation success. And remember, then the point about this is that all the embryos transferred are euploid. They've all been tested by PGS. So there are 244 PGS cycles, leading to 196 embryo transfer cycles from vitrified embryos. The embryos had all undergone day 3 laser zone ablation as part of the PGD process, biopsy on day 5 or 6. And this is a key thing to remember. So embryos aren't always able to be biopsied on day 5, and sometimes you have to carry them over to day 6 to be able to do it. Biopsies were done with Array CGH, and grading of embryos was done. So main thing from the study was to compare embryos that had either been tested on day 5 or tested on day 6. The day 6 embryos, slower growing and potentially less good. And I think we all know historically that day 6 embryo transfers have been traditionally quite bad. And certainly in my group, we're always very wary of doing day 6 transfers because of historical reasons. But in this situation, these are embryos that have been tested chromosomally. They've done PGS. We know they have normal chromosomes. And then they're frozen and put back another cycle. So as you can see here, first of all, there was no difference in the euploid status between embryos tested on day 5 and day 6. And then the pregnancy rates also appeared to be the same. So whether you put these kinds of embryos back on either day 5 or day 6, these are embryos that have been shown to be chromosomally normal. The pregnancy rates, the implantation rates, 79% and 77% were about the same. Also very similar miscarriage rates. However, they did note in the study that there was a slight increase in miscarriage rates in embryos put back on day 6. And they hypothesized in their study that with a bigger group, it may well turn out that day 6 is slightly worse, but only marginally. And you can see that's actually pretty comparable. This interesting graph they show is success rates across ages. And you can't help but be amazed by these success rate numbers. Remember that these were the best embryos that they had, AA quality, the best morphological embryos they had, which had been tested chromosomally. The success rates are similar across ages, and I think these are very high rates, but I think you should remember what we're comparing here. These are very highly selected embryos, the best grades, and the fact that they quote 100% success rate for women aged 43 and 44 is, for me, probably excessive and must be a huge selection process. But they are trying to show that success rates can be good in this context. So high success rates can be achieved incorporating PGS and vitrification independent of the development process of the embryos. As long as they reach a stage where they can be biopsied, they do well, and it doesn't matter if you hold over to day 6. So they do anticipate that a larger database may reveal slight differences in day 6. There was a trend, but it's not a huge trend. And in fact, in our own lab in Sydney, we've started doing this quite a lot as we've moved to day 5 biopsy. Often it's just not possible to do, and you have to hold over to day 6. So this is actually quite reassuring from a practical perspective. Day 6 biopsy is fine, and they do well. A last little question for everyone. Autotransplantation of frozen thawed ovarian tissue restores ovarian function in 36 out of 39 cases with an 18% pregnancy rate. Is that true? Is that possible? Or is that completely ridiculous? Thank you. So A1 was that true? Yeah, so most people think it's true, obviously, because I'm leading you along there. So the next slide is this presentation. So this is from Germany. It's the last talk of this presentation. So cryopreservation, so different topic to vitrification now, cryopreservation of ovarian tissue and subsequent retransplantation following a period of recurrence-free survival, as we've heard in the last talk before lunch, is very promising for fertility preservation. As we heard, in fact, 30 pregnancies have been reported worldwide, and we expect many more will come through with this. Cancer patients who are cured and survive and want to reproduce after that. So the idea of this study was to look at the success in terms of endocrine activity and pregnancy rate and success rates in a particular network, which they call Ferti-Protect. It's a German network. So a number of different centers pulling together a whole bunch of patients. So this was a retrospective clinical case series of 39 cancer patients, mean age 34, done between 2007 and 2013. So they completed their cancer treatment in this network of about 100 centers in Germany, Switzerland, and Austria. And the ovarian tissue was cryopreserved by slow freezing, and the tissue was retransplanted in the pelvis, either on the side wall or in the ovary. So as you can see, most of us were right with my leading question there. Incredibly, 36 out of 39 patients did regain ovarian function quite quickly, between 6 and 24 weeks after transplantation. And this was assessed by follicle development and estrogen production, and only 3 of the patients failed after 6 months. That's an incredibly high rate, I think, and we should be very encouraged by that. Some of these patients have gone on to become pregnant, and their pregnancy rate is indeed 18%. So some have given birth, and some are still in ongoing pregnancy. You can see that some patients conceived spontaneously, and some had IVF. So it really does look like this process works pretty well with very reasonable rates. Patients are young-ish, although some are older. You can see there was a 37-year-old and a 38-year-old who actually both got pregnant. So really interesting that this can work. Autotransplantation of this tissue restored ovarian function in 36 out of 39 cases, and pregnancies were achieved in 7 cases. So this is a good method to restore fertility in women suffering cancer. Definitely an encouraging method of reestablishing menstrual cycles and achieving a pregnancy. It is hard, I'm sure. I don't know how many of you would do this yourselves, but it does require a specialized team. Freezing the embryo, preparing the ovarian tissue, and freezing it correctly, and then putting it back requires quite good surgical skills, and a probably specialized team is very important. So, summary from this talk. We've learned in the first talk a population-based study that compared with slow freezing blastocysts, vitrification of blastocysts resulted in significantly higher pregnancy rates and delivery rates, as well as comparable neonatal outcomes at a population level. And also that study suggested that vitrification could be considered as an alternative embryo transfer strategy to improve overall clinical outcomes. Remember, perinatal outcomes seem to be better in these babies compared to fresh transferred babies. Second talk showed that implantation pregnancy rates are superior when the frozen embryo transfer is performed in clinical situations where fresh transfer is contraindicated. Again, this is pointing towards the direction that maybe this is a good strategy in everyone even. Our third study showed that in advanced maternal age population, high blastocyst survival and implantation rates can be obtained after vitrification, even when low numbers of embryos are available. The study from Belgium showed that multiple pregnancy rates were doubled if you had a double frozen embryo transfer of vitrified blastocysts compared to slow frozen embryos. So should a single vitrified frozen embryo transfer strategy be introduced to everyone, or certainly younger patients, when we use vitrification? Then we looked at that study from California, where you could get a high success rate using PGS and vitrification. It seemed to be independent of the developmental progress of the embryos and the morphology of the embryos, but more data is needed there. And finally, we showed that transplantation of ovarian tissue is a really encouraging method now to reestablish menstrual cycles and achieve a pregnancy.